Trying Again tells a story of miscarriage. It's a personal podcast of passion as I explore this usually silent world and decide whether I want to try again after multiple miscarriages. I'm Rachel Smith. If you're listening to this without listening to episodes 1 and 2, it's maybe best to go back and listen to them first, else some of this might not make any sense. And thank you if you're still with me on this journey. This is episode 3. The conversations in this episode will be frank.
Wonderful, you're doing really well.
And they may be difficult, but they are needed.
The best you can do is have more good months where you've got a really good lining and a really good embryo.
In this episode, I will be sharing what happened next, and I will talk a bit about the research going on at the Tommy's Miscarriage Research Centre. A bit about the centre. It's the biggest of its kind in Europe, sharing research facilities in partnership with the University of Birmingham, the University of Warwick, and Imperial College London. The 3 sites run specialist clinics enabling women to access treatment and support and participate in Tommy's research studies. Lee and I visited Tommy's in Coventry University Hospital on referral from my doctor for specialist treatment from Professor Quenby, Professor Brosens and their team. After we lost baby number 4, we booked in for NK cell testing.
By taking a biopsy, we will induce a repair response, which is thought to make the lining of the womb more receptive in cycles to come. We're going to use the sample for this natural killer cells testing.
This is Professor Brosens talking me through the paperwork before going for the procedure.
If there's surplus tissue, can we use it for research?
Yeah.
Good, because I was about to say you can't say no. So if you don't mind initialing this box, this enables us to do research.
Picture it, if you will. There's a small but comfortable doctor's room with a bed and a curtain that's been pulled around. The nursing staff helped me into bed and talked me through using the gas and air supply before measuring my womb lining so they can take a biopsy of it for testing.
Grab hold of this thanks for offering. I don't need it anyway.
Obviously, gas and air is not something I'm used to using, but I do have a PADI licence for scuba diving at a basic level, and I've had years of practising meditation, so I figure all I need to do is focus on my breathing. And that's what you'll hear. Lee's in the room with me.
So, what you do, pop it between your teeth, close your mouth around, and then deep down.
Deeper than that, right?
You need to make that whistle sound, yeah? That means it's working. And you do it slow and steady.
I'm concentrating on making the whistle sound. The results from this test will show whether I have increased levels of natural killer cells, or NK cells. If you Google NK cells, you'll read that these cells are part of the immune system that humans are born with and can destroy tumours and infected cells. There's a blog post written in 2017 on the Tommy's website that explains the testing of these cells. It says, due perhaps to their name, many women fear that these cells are attacking and killing their embryo. The article goes on to say, natural killer cells are actually special immune cells which clear out aging cells in the womb lining. The article goes more into detail, explaining research is indicating that a balance between natural killer cells and aging cells in the womb could actually be to blame for miscarriages. Lee and I weren't sure whether this was the case for us, but if there was a slight chance it may be, and if a biopsy of my womb lining helps me find an answer, then we thought this was a wise move to make.
There we are. All done. Now pop it out, or it'll be no good to the world when you have to go. Well done, you did really well. Yeah?
Let me introduce you now to Professor Quenby, who can explain more about the research taking place in Coventry and with the Tommy's Miscarriage Research Centre. I joined the professor online. She sat in her living room talking to me in my newly formed duvet den. How are you well?
Yeah, fine, thank you.
Lovely. I'm not even going to begin to try and explain the professor's full title. I'll let her do the honours.
So it's Professor Siobhan Quenby. So I'm Professor of Obstetrics at University of Warwick, and I'm also an honorary consultant at University Hospitals Coventry and Warwickshire NHS Trust.
Okay, and what does that mean?
So that means I spend half my time doing research and half my time doing patients. So most of my research is on recurrent miscarriage, and most of my time with patients is spent with recurrent miscarriage patients.
What made you want to do this? Because I've read on the Tommy's website you've been studying recurrent miscarriage and miscarriage for over 20 years. What started it all for you?
So basically, when you're a junior doctor, you do a research degree. So I did mine in recurrent miscarriage because at the time of being a junior doctor, I felt that a lot of people were miscarrying and there was very little medical research done in that area and very little treatments that we could give the patients. So I wanted to do my degree in recurrent miscarriage, and then everything else has followed from there.
So it just came from university. It's almost like Facebook, but for miscarriage. What's been a moment for you when you just think you're really pleased about the progression you've made with things?
There's sort of two things on a sort of individual basis. It's obviously fantastic when people who've had a lot of miscarriages have babies. So there are some people who've unfortunately had an awful lot of miscarriages under my care, who we've been through for every single miscarriage. And then when they finally make it, it's fantastic. So on a personal level, we actually have a lot of really good moments when you see their face and their husband's face and or their partner's face and the face of their grandparents. It's really, really fantastic. On a research level, the research is proven to be really, really challenging, and it's really actually very, very difficult to get really good evidence that we've got a really good new cure and a new treatment. And it's been more of a sort of chipping away process. So each year we find out a little bit more, and it's like putting together this massive jigsaw puzzle. What hasn't happened, that we haven't had this like major breakthrough that says, wow, we've got a fantastic new cure, and I'm beginning to realize that's not going to happen. What is going to happen is we're going to make a little bit of progress and make a little bit of difference each year. So for example of this, I was involved very closely with Professor Kumarasamy from Birmingham, who's actually the head of the Thomas Research Unit. And we've done trials of progesterone to try and find out whether progesterone prevents miscarriage. And this has been going on for nearly 10 years, because we did one trial and then we did another trial. And it wasn't until we put the data from the two trials together that we actually realized progesterone does prevent miscarriage. But it involved recruiting literally thousands of women and a huge amount of work, asking lots of people to be randomized into the trials. And then it doesn't stop every miscarriage. It just improves your chance a bit. And I think I've realized over the years that is the best you're ever going to do with new treatments. You're going to improve people's chances of having a baby, but we're not going to make some massive big change. We've just got to have more and more options to improve people's chances bit by bit and be much more. I think that's the way it's going to go now.
I had read in the past it was used as a placebo, and I was all a bit confused. But then, so that's really good from my point of view, selfishly, because I'm going to have to talk to my GP at some point and discuss maybe having that if I decide to try again, because I've delayed it for all sorts of reasons. But now it's coronavirus. But yeah, I delayed it. Oh, you doggy.
It's not supposed to go up the stairs.
Sorry, I digress.
Dear. Dear.
The trials that I've had, I wanted to just have a chat about. I don't really understand that much about the science that went on behind them, to be fair. When we first came to see you, I had my general bloods taken, and then we had some bloods taken for sticky blood, and I had a phone call conversation with you, and both of those came back okay. And then I came in to have NK cell testing, and that was the one I was that was a little bit more involved in taking blood. And I'd be really interested to know what you were testing for with them.
The problem with recurrent miscarriages, the tradition is to take blood tests, and at the best, they show things that are associated with miscarriage. They don't really get to the bottom of why people actually miscarry. Whereas the actual reason that people miscarry is much more commonly going to be a problem in the lining of the womb. So we are convinced of that. The difficulty is developing a test of the lining of the womb that tells us who would benefit from a treatment. And that's what I've been working on for years and years. And so the NK test I worked on for a lot of years, and it is useful because it tells us all sorts of things about the lining of the womb. And the more we research, the more we're sure that you do have to have the right balance of NK cells in the lining of the womb in order to have a successful pregnancy. So we have made that progress. The problem is that, the lining of the womb regenerates every month. So the lining of your womb 1 month might be different the next month, which is not really very convenient, because if we test the lining of the womb 1 month, then it may be different the month they get pregnant in. Our way around that is to do the test twice to try and get an idea of how much people's lining, how much variation there is in the lining of the womb. So we found that some people's is very similar and some people's varies a lot. And so we are desperately trying to get a really, really good test, but it turns out that the difficulty is it's then a balance. So you need, like, NK cells aren't all bad. You need some NKs to help implantation, but you don't want too many or in fact too few. So it's trying to detect whether people's balance is roughly right. And then we've now realized it's actually a balance between the NK cells and these stem cells or rapidly growing cells, and these other cells called senescent. So it's a balance of 3 different kinds of cells. So we're working on a test that would maybe be better, that tells you about the 3 different kinds of cells and their balance. But even then, we've got a lot of hurdles to overcome because of this business of the lining of the womb changing every month. So it is a very, very challenging area. And that is why we don't have this magic. Unfortunately, we don't have this massive easy cure, but we do know that progesterone pushes everybody's lining in the right direction and makes everyone's lining better. So that's one thing we've got. We do know that if you have very high levels of NK cells, we can reduce them with steroids. So we've got that in our armory. And then we are hoping to work on a treatment for people who've got low stem cells as well. So I think the future is going to be trying to be much more subtle and understanding this balance, and then giving people the right target for the right balance, you see. But what I want to do is try and increase people's chances and try and get people more good months. So I've realized the best you can do is have more good months, and more good months where you've got a really good lining and a really good embryo. And that's the game we're trying to play, which is hard.
It feels like nature's just going to keep slapping you with things.
Yeah, and the big difficulty is that there is a lot of abnormal embryos in human reproduction. So you can get the patient perfect, but then that month it's an abnormal embryo. So it's all increasing people's chances. And so we have to deal with a lot of emotions and how to deal with that, because that's quite difficult to deal with. The uncertainty, because we never know what's going to happen next, and trying to make sure we've done everything we can to maximize the chance there. And that's very hard.
No, it's a real life soap opera, isn't it? I know, if nothing else, we can get a form of answer, even though I actually haven't had anything that is wrong, which is actually maybe easier to have something wrong, because then I can fix it or I can do something. So I'm kind of just hopeful and thinking, if I follow the advice, it might help, but it isn't going to be the magic pill that will give me my baby. So I think I'm a bit more realistic.
I think that's really important. I think we need to change our language to people, because I think it's wrong to give people false hopes, because even if you do find something in the blood tests and you give them the treatment, if in that pregnancy it was an abnormal pregnancy, then it's not going to work. People want to come to us and they say, I want this definite cause and I want you to cure it, but it isn't like that in miscarriage at all. So it's really being very clear about what our job is to support people, because some of them are going to be okay, and also to be very, very realistic with them. And the more I've done the job, the more I realize it's really important to be really, really realistic and honest with people. And I spend a huge amount of time in clinic trying to explain to people that if you've had lots of miscarriages before, the hard truth is you have got an increased risk of miscarrying again, but we can do everything we can to support you and everything we can to increase your chances, and somehow trying to get people to keep going. And it's hard. It's really hard to get people to keep going, and some people's relationships split up, and it's because the stress between them. So we spend a lot of time trying to talk to the husbands as well, or the partner as well, and make sure they're part of the team and they both cope. And we've been doing some studies on that, like anxiety and depression in patients, and the results were quite shocking. It was even when we got them to fill in questionnaires, it was even more obvious than it is in clinic. Sometimes the woman's dealing it very well and the husband's just gone to bits. And sometimes it's the other way. Well, the husband's dealing with it well and the woman's gone to bits. And it's important that you support both people, because in those sort of things, sometimes the husband walks off or the partner walks off because he can't take anymore. So when you support people, we've got to remember we've got to support them as a couple, because they've both got to go through this, and trying to manage people's expectations and say, you can, I'm very confident you'll get there in the end, but it's hard, and prepare people for that. Otherwise, if they do miscarry again, it's really, really tough. So we work really, really hard as a team to prepare people and make sure we're there for them and listen, which is basically So it's quite a complicated, it's quite an emotional thing. And I, after all my dreams, I accept now that I am not going to have something that stops all miscarriages. It's not going to happen. So, but we can each year make it better for people. So I want people to miscarry less, and that's the real world.
Looking back to your student self, would you have gone on the journey? Would you knowing what you know about it, or would you have picked something else for your dissertation? Please say no, but would you have?
well, no, I love the job, but I was hopelessly naive when I started. I honestly thought I'd be a lot further on now than I am, and I think with age you get realism, much more realistic now. But I mean, the patients that you deal with have been fantastic, and there's some really memorable patients that you really, really get very fond of, and so all that bit's been fantastic. And we have made progress in the research, but from my young self, it isn't what I hoped. I hoped, as you do, as we all want. I hoped that I'd have this test and this magic treatment, and everything will be marvelous. But all that happens is that, in fact, the more research you do, the more you know, the more you realise how difficult it is, and the more circumspect you are about what you say, and the more I've realised. I did realise that to start with, but in a more profound way, how important it is to look after people during this journey. Because one of the things that one of my colleagues has done in London is realised how much post-traumatic stress people get after a miscarriage, and how much mental health damage it's done. So the idea is that we do our best to support people to look after their mental health as well, so that the process of miscarriage doesn't do unnecessary damage to them or their partner.
Because of what you've seen and what you deal with daily, I've only had my experiences. I can't imagine having to have the conversations that your team have had with me, with other people, as a regular conversation. I can imagine that gets really, really draining.
Yeah, and it is important that you're part of a team. So yeah, and you don't you don't work on your own. So we have a supportive team, and then nationally we have a thing called the Association of Early Pregnancy Units, where we have an annual meeting and get sort of support, because the people who do this, you do get very drained. And I think the thing we're most terrified of is getting compassion fatigue. So that if you see too many people, you can feel your compassion disappearing, and you don't feel human anymore. So it's very important that you have those. So it's very important that staff give each other support. And so in the Tommy's team, that's one of the big good things about Tommy's being part of a national centre, having lots of regular meetings with people who do this all the time. And we need a lot of interactions. We talk a lot and laugh a lot as well.
Where's Tommy's place in? Because it says it's the biggest in Europe. Where's its place in miscarriage research in Europe and with places like North America and other places where there might be research happening?
Oh, so the Tommy's are by far leading the world. So we're definitely the top place in the world now, because it's such a powerful team between us and Birmingham and Imperial, and the research we're doing is so much further ahead than anybody else now. That we're really, really making huge difference.
And are they coming to you for advice then?
So we're working mainly with sort of European countries and North America. And then Ari particularly is also doing some projects in Africa and Pakistan, in developing countries. So that's right, yeah. So we have got a global spread there to try and improve the care of people miscarrying everywhere.
And what's the hope with that? Will the research come back into Tommy's?
Well, it's interesting. When you do research in developing countries, the learning goes both ways. So one of the things that happened was, traditionally, when I started in this country, if you had surgical treatment of miscarriage, you always had general anaesthetic and did it when you were asleep. But in the developing world, they had developed a technique where you could do it with people awake. And now the surgical management awake is now something that's been introduced into this country, which is really important now since the COVID's been on, because the access to surgical management under GA has disappeared, and now everybody has to have the one that we actually brought in from Africa, which is cheaper, quicker, and it's much better for the patients to have your surgical management with your awake, basically.
How do you think your research will continue?
Basically, gradually reopening all the research. But it's just to reopen it with social distancing in place, which is the challenge. The big thing I'm doing at the moment is looking to see how many people have chronic inflammation in the lining of the womb. If they've got this chronic inflammation, we're looking to see if they've got some difference in a thing called the microbiome in their vagina and their endometrium. So we now understand an awful more about bacteria than we used to. So we used to just think there was a few bacteria in your vagina and a few bacteria in your endometrium. But we now know there's actually literally hundreds of different bacteria, and it's the balance of the different kinds of bacteria that affects whether or not you miscarry or have a successful pregnancy. So we're trying to find out if the imbalance in the bacteria causes the inflammation in the lining of the womb, which causes the miscarriage.
There's one thing I did want to also ask, because when we came to see you, it was after we'd had 3 miscarriages, and I know that was the NHS advisement for their referral. What's your thoughts on having 3 miscarriages before there's a referral to trials like you're doing, or to Tommy's?
So we're desperately trying to change that. So we're working on a new care pathway, so that even after 1 miscarriage, you get some treatment, because I really want to move away of this ridiculous 3 miscarriages, because it doesn't mean anything scientifically. It's an idea that got introduced in the 1950s that unfortunately is very difficult to get rid of. So we're trying to change it to a system where after 1 miscarriage, you get some advice, because you can have post-traumatic stress disorder after 1 miscarriage. So after 1 miscarriage, you get some preconceptual advice about lifestyle, and make sure you haven't got any major illness, and some signposts to sort of self-help groups. Because obviously these things can't cost the NHS any money, but all that hasn't cost them money. Then after 2 miscarriages, everyone would get a few blood tests, and then after 3 miscarriages, more blood tests. So we're calling it the graded approach.
Okay.
And the idea with that is twofold. One is that when people have 1 miscarriage, they're completely ignored, but also they're not given straightforward lifestyle advice, so we're not doing any proper preconceptual counselling and not getting people as fit as possible for pregnancy, you see. So we're trying to change it so it's not about how many miscarriages you have. It's after every miscarriage, people get some advice as to how to improve their chances next time. But how far we go increases with the number of miscarriages. So we're going to try and get rid of the term recurrent miscarriage and have a graded approach to miscarriage, so everyone who miscarries gets something. That's where we're really fighting for that as a Tommy's team at the moment.
I'm not sure about you, but I'm very excited at the thought of official care being updated for all women facing a miscarriage in the UK. If you've listened to episode 2 of this podcast, you'll know Lee and I have been through the mill a bit with our experiences. We will never know if having official support after 1 miscarriage would have reduced the others. But the thought that other women don't have to suffer in the same way and it becomes a norm that they get support after 1 miscarriage, well, that can only be a good thing. It's likely I will be coming back to the work at the research centre throughout the podcast. As you can imagine, it's very evolved and moving and changing, so I'll be keeping an eye on any developments, and if I see any, I will try and share them with you. If you were wondering what my results were for my NK cell test, they came back normal. I have a letter to share with my GP with recommendations. The letter is full of detail that's really helpful, but a bit mind-boggling. Some lines that make sense are: there was no evidence of heightened inflammation in the lining of the womb during the implantation window. And a line I don't like as much: the recurrent miscarriage phenotype is both striking and relatively rare. The letter provides recommendations for my future treatment if I decide to try again. The treatment involves drugs, and we need to have a think if that's something we want to do. I'll keep you posted on that one. This episode was recorded and produced by me in my spare room, with a duvet for a sound barrier and a camp table for a desk. A huge thank you, of course, to Professor Quenby for joining me on this episode. Also thanks to Professor Brosens, Tommy's, University Hospital Coventry, and the nursing team at the centre. If you're going through it right now, please know you're not alone. I'm here if you want to share your story, and if you need support with any of the issues raised in this podcast, there's links to help available on tryingagainpodcast.com. If you've liked this episode, please share it with others or leave a review on your podcast provider. And if you haven't already, remember to subscribe to this podcast so that you don't miss an episode.
You can wrap your fingers round my